Good afternoon and welcome to today's webinar, Introduction to Vascular Interventional. My name is Michelle Farley, and I'm the Marketing Communications Specialist at IAC. And with that said, I will now introduce today's speaker, Laura Humphries, IAC Director of Accreditation for Vascular Interventional. Laura?
Thanks, Michelle, and thanks to everyone who is joining us today. The weather here is beautiful near Baltimore, Maryland. I hope that you are having just as beautiful weather as we are. Today's objectives, we are going to provide a brief history of IAC accreditation. We're going to review the application requirements for vascular interventional accreditation, discuss a little bit about the application process, and recognize the importance of a quality improvement program. For those of you who are not familiar with the IAC, we are the Intersocietal Accreditation Commission, and our mission is to improve healthcare through accreditation. A little more information for those of you who may not be familiar with our previous programs in the testing, in the diagnostics, or in the vein center division. The IAC started in 1990 with vascular testing. Since then, we've added several programs up until our most recent programs in 2022, which include the three we're going to be talking about today, which are deep venous intervention, peripheral arterial intervention, and hemodialysis access, as well as device clinics and perioperative TEE. Those are also new divisions, but those will be discussed in a different webinar. The IAC is a nonprofit professional organization, 501c6. For those of you who don't know that, I mean, that is what our mission is, to improve healthcare. We are a nonprofit. We are in it for the long haul. We're not in it for anything other than to improve healthcare. We have 30 years of experience. Our board is made of various specialties in medical fields. Since its inception in 1991, the IAC has granted accreditation to more than 1,400 sites. We are recognized by CMS as an accrediting organization for advanced diagnostic imaging, and we have more than 40 medical societies that send representation to our various board of directors across all divisions. Here's an example of all the sponsoring organizations, or some of the sponsoring organizations that do support the IAC. We are proud to have people from all over different specialties to be able to contribute to our standards. So those of you might be familiar with our Vein Center accreditation program. Vein Center was started in 2013. Since then, we decided to move into the vascular interventional space. We did this so that people could demonstrate that your practice meets the kind of current multidisciplinary national standards established by IAC for vascular interventions. And we did it because, we found out that providers want to know if they're doing appropriate work. And if they do, they want everybody else to know it. So they want to have that IAC stamp of approval. So who are we? So the Vascular Interventional Board officers, they include Mark Meisner, who is our current president. Deepak Nair is our president-elect. Tom Rook is our immediate past president. Kathleen Osvath is our officer at large. And Dominic Zambuto serves as our secretary. Additional board members include Dr. Carl Fastabend, Dr. Lurie, Dr. Rosenfield, Dr. Lohr, Dr. Moore, Dr. Scoble, Sarah Schonsberg, and Dr. Espinosa. So here we are. Let's talk about, are you currently accredited in Vein Center with the IAC? So like I said before, vascular interventional is comprised of the Vein Center, which is the superficial venous, deep venous, peripheral arterial, and hemodialysis access. You can do all or one within your program. So that brings us here to the first poll question. If you would take a minute to answer that and let us know if you are currently accredited with the IAC in Vein Center. You can answer yes, no, or no, but I want to be. And I will give everyone just a few minutes to answer that question for us so we can see what everyone's status is here. Okay, so it looks like, 31%, which I'm surprised at, 31% are currently accredited in Vein Center, and they're interested in the new programs. 61% are not, and that's fine as well. And then 8% no, but you want to be, and that's what we're here for. So a little bit about the application requirements for these programs. First and foremost, you want to look at the standards. We have standards for each one of these different programs. For the superficial venous, deep venous, hemodialysis access, and peripheral arterial. They're all under the vascular interventional umbrella. Testing you can apply for venous, arterial, visceral, carotid. Well, very similar to here on the Vein Center, you can apply for superficial, deep, peripheral arterial, and hemodialysis. If you're performing deep venous procedures in your facility, the following procedures are covered under this accreditation. Invasive diagnostic testing, which includes venography or IVUS, venous angioplasty and stenting, treatment of pelvic venous reflux, IVC filter retrieval and repositioning, IVC filter placement, treatment of venous malformation, and invasive treatment of DVT. Again, you don't have to do all of these procedures. The procedures included in the peripheral arterial section include angiography, stent placement, thrombectomy, angioplasty, atherectomy, cerebrovascular therapy, EVAR, embolization therapy, and IVUS. And last but not least, in our hemodialysis access program, we have angiography and or IVUS, AV access creation and insertion, angioplasty, stent or stent graft placement, catheter removal, embolization and injection therapy, catheter placement or revision, and treatment of thrombosis. In order for your staff to meet the requirements to apply for these areas of accreditation, they must meet certain pathways for credentialing, for volumes, your ACLS, and different CME requirements. Staff members that are included in this are your medical director, medical staff, medical physicist, interventional technical staff, APPs, and nursing staff. For facilities applying, for the medical director or the medical staff, they must be board certified in either general surgery, interventional cardiology, interventional radiology, vascular surgery, nephrology, if you're applying for hemodialysis access, or an ABVM, endovascular exam diplomat. Case requirements for your medical director and medical staff. If you want to apply in the deep venous section, these case volumes are over the previous 3 years. These are requirements to be eligible. I will say that these can be done anywhere. They don't necessarily have to be in the applicant facility. For venography, it's a requirement to have 20 cases over the previous 3 years. IVUS as well, 20 cases over the previous 3 years. And the remainder of the procedure types, angioplasty, treatment of pelvic vein reflux, IVC, placement, retrieval, repositioning, DVT, treatment of venous malformations, they're all 15. And again, as you notice here, it says if performed. In order to apply, you do have to have cases in venography and IVUS. And then the other cases, if you do perform them, you would have to meet those volume requirements. Peripheral arterial, same thing. Cases over the previous 3 years can be done in any facility. These are a little bit more complicated. Angiography is the must all have all at 40 cases. And then if you're performing any of the other procedures, you must have the case numbers listed in parentheses. As far as IVUS, it's 20, angioplasty 30, stent, atherectomy, and thrombectomy are also 30. Thrombolysis is 15, and then embolization therapy, EVAR, and cerebrovascular therapy are 10 cases. Finally, hemodialysis access, we kind of make this one a little bit different. This is a total volume. So you must have performed at least 60 cases over the previous 3 years, and they can be within any of these procedure areas. CME for the medical staff, medical director and medical staff, they must obtain a minimum of 30 Category 1 CME credit hours related to the procedure area. So if you're applying in deep vein and arterial, you have to have 30 in deep vein, you have to have 30 in arterial. You also have to have at least 2 hours of fluoroscopy radiation safety training. Those must be obtained as part of your 30 CME. Provisional medical staff. So if you have staff members who meet all of the criteria except they just don't have the case volumes, that's okay too. You can list them in the application as provisional medical staff members. They must perform a minimum of 5 cases under the direct supervision by a qualified medical staff member. During that time, the medical director is responsible for reviewing the case log, including all the outcomes relating to the procedures. And that provisional medical staff member must obtain full medical staff status prior to reaccreditation. So you can't be a provisional staff forever. So your accreditation runs in 3-year cycles. You have 3 years to get those volumes so you can be a permanent regular staff member. Your interventional staff members, they must be registered. They must be a radiology technologist. They must hold one of those credentials below, the ARRT, CAMRT, ARRT-CB, ARRT-CI, so many letters. And they must have a current BLS. The interventional staff must obtain a minimum of 15 hours of Category 1 AMA or RCEEM approved CE in the past 3 years. And something down there in italics there, at least 2 of those hours of CME must be related to fluoroscopy radiation safety. Your APPs, these are your physician assistants and your nurse practitioners. They must perform under the direct supervision of a physician and evaluate a minimum of 50 patients over the previous 3 years in order to apply for accreditation. They must have current BLS or ACLS. And they also must obtain a minimum of 30 Category 1 CME hours in that related procedure area in the past 3 years, with at least 2 of those CME relevant to fluoroscopy radiation safety. Nursing staff. This would apply for your RNs, your LPVNs, your LVNs. They must have your current BLS or ACLS. They must obtain a minimum of 30 Category 1 hours or Category 1 CME in the past 3 years in the related procedure area. And again, at least 2 hours of the CME must be relevant to fluoroscopy safety. The medical physicist, and I think this might be the last one. Your facility must have a qualified medical physicist appointed. Their qualifying pathways are listed below. You need board certification. You could have passed part 2 of the ABR exam and completed the CAPMP approved residency in medical physics that includes diagnostic imaging, or you must have a license or certified in accordance with state and local regulations as a diagnostic physicist. Again, full certification is required prior to the next accreditation cycle, which is kind of similar to your provisional staff members. The medical physicist must obtain at least 15 credit hours of CE approved by the Commission of Accreditation of Medical Physicist Education Program. And that's why we have all of those letters and initials. So let's talk about emergency supplies and medications. We'll move on from the staff members now. You are required to have oxygen, methylprednisolone, antihistamines, local anesthetics, anxiolytics, insulin, contrast agents, albuterol, dopamine, furosemide, an AED, epinephrine, analgesics, sedatives, saline, antihypertensive meds, anticoagulation meds, calcium chloride, fumazanil, and lidocaine. More tongue twisters. More additional medical supplies include magnesium sulfate, sodium bicarb, vasopressin, hydralazine, beta blockers, succinylcholine, and verapamil. For these emergency supplies, you must have a monthly inspection log to make sure they're all in there. They must be clearly labeled for emergency use only, and they must be secured with a plastic lock. We get a lot of questions about the plastic lock. The reason being is we want you to be able to break it quickly should there be an emergency, but we also don't want any sticky fingers in there. So we want to make sure, somebody doesn't have a headache, comes and takes your aspirin, and then you're out of aspirin. So just make sure you have that plastic lock. Make sure, it's easily broken, but everything is secure. If you're doing moderate sedation monitoring, you must have non-invasive blood pressure, ECG monitoring, pulse oximetry, and epinephrine. And that brings us to our next poll question to see if everyone is still awake here. What is your highest level of sedation that you use for vascular interventional procedures? Is that mild, moderate, deep, or general? This is not a trick question. We're just trying to get a feel for where everyone is with their sedation at this point. Let's give everybody just a couple more minutes. Okay, so it looks like the majority of you use mild sedation. Moderate sedation is quickly behind. Mild was at 40, moderate's at 36. General sedation is 19, and 3% are using deep sedation. Talk a little bit about your documentation, your pre-treatment documentation. This is your H&P, your clinical evaluation. This must include chief complaint, family history, symptoms and treatment history, a directed physical exam, a VCSS score if you're applying in deep venous, an indication for the procedure, lab studies, patient medical history, history of VTE, again for deep venous, anticoagulation medication and treatment length, CEAP, SEEP score for deep venous, additional imaging, and a treatment plan. Pre-procedure documentation includes consent form, list of allergies or no known drug allergies, an ASA score, name of treating physician and patient, and a Mallampati score if using sedation. Intra-procedure documentation includes your timeout. You also must record vital signs at least every 10 minutes when indicated, or if you're using your moderate sedation. This includes your blood pressure, pulse oximetry, a pain scale assessment, level of consciousness, EKG, and your respiratory rate. Your operative report, this must include an indication for the procedure, treatment success or inadequacy, sedation or monitoring provider, documentation of sterile prep and drape, the access site, technique, access needle and sheath, contract type and volume, structures imaged, operative findings, devices used, all medications used, patient status at the end of the procedure, fluoroscopy exposure, the name of the surgical assistant and or circulator, description of the procedure, complications, number of minutes of sedation and agents used, treated vessel, name of person performing procedure, and estimated blood loss. Sounds like a lot, but I can guarantee the majority of you are probably already capturing this information. You just don't realize it. As far as your patient instructions, they must include the procedure performed, anticoagulation or antiplatelet therapy and monitoring instructions, compression instructions if necessary, patient activity, ambulation, and exercise, directions and contact info to access the healthcare team, follow-up visits, management of post-procedure pain, the access site, dressings and wound care, bathing or showering instructions, air and car travel restrictions, and follow-up office visit instructions. You are required to have protocols and policies in place. Among these policies and protocols, and all these are in the standards. You will get a copy of these slides if you request them, but these are all also listed in the standards. You must have a policy for the management of allergic reactions, the infection control policy, treatment and or referral for patients with complications, protocol for each procedure performed, incident reports or adverse event policies, a patient pregnancy policy, a patient pre-procedure preparation policy, contrast medication administration and supervision policy. You must also have a protocol for patients requiring escalation of care, a radiation dose evaluation policy, post-procedure follow-up policy, protocol for disposal of used or expired supplies, policies, protocols, and procedures regarding administration and supervision of intravascular contrast agents, patient customer complaint policy, primary source verification policy, patient confidentiality, a protocol for sterilization, radiation safety, and record retention. That brings us to our next and I think final poll question. Now that you have all the information, what are you interested in applying for? Are you interested in applying for peripheral arterial, deep venous, hemodialysis access, or do you want to apply for all of them or more than one? Let's open the polls here. Give everybody just a couple minutes. Excellent. So it looks like 45% of you are interested in applying for more than one program. That is wonderful. 25% are interested in deep venous, 20% are peripheral arterial, and 9% are hemodialysis access. And like I said before, this is a la carte. You can apply for one, you can apply for all, and you can also, if you're doing your superficial venous procedures, you can add those in here as well. Let's talk a little bit about the application process. So this is a little bit different than the vein center application. For these new procedure areas, you start with a facility assessment. That's your own assessment. Do I have the policies? Do I have the volumes? Do my staff members meet the qualifications? Things like that. So you do your own assessment to see where you're at or where your deficiencies might lie. And then you start and submit the online application. Now I have the facility assessment and the online application on 2 steps here, but really I kind of like to combine those two. I usually tell people the online application is really used as a guide to tell you what you have, what you need, what you might need to work on. So what I usually recommend people to do is just start the application. There's no fee to start the application. It doesn't expire. It goes pretty much through the standards to say, hey, do you have this? Yes or no? Do you have this? Yes or no? If your answer is no, then you know, hey, let me go back to the drawing board. I might need to create this policy. So that's kind of what I recommend people to do. Once you've submitted your online application, we will come out for a site visit. All interventional programs get an on-site visit. So we will come out, we will spend the day with you, check out your procedures, look at your procedure area, evaluate sterile technique, things like that. If we need any additional documentation, we'll look at it at that point. All that information will go to our board of directors that I spoke about earlier. They will review all the information and they will give you the grant or they will identify deficiencies that maybe need to be fixed. If you are interested in applying for more than one modality, you can apply for all of them at one time. And while this does seem like a lot of work, and I can appreciate that, I usually recommend people to just go for it. Apply for more than one at the same time, because we run 3-year cycles. So if you say, okay, well, this year I'm going to apply for vein center, and then next year I'm going to apply for arterial, then the following year I'm going to apply for deep venous because it's just too much work to do all at once. Well, now you're just going to be doing accreditation all the time. So if they're all in the same 3-year cycle, it just makes things a little bit easier. So I do recommend that. If you don't have the time for it, that's fine. But we are here to help you with anything that you might need during the process. So please always feel free to reach out to us. We're happy to do a little bit of hand holding. To access your account, you would go to the online portal. It's intersocietal.org. You can either go up and start your new application according to the arrow, or you can access an existing account. If you already have an account, you can add the new procedure areas there. To create an account, first you enter all your facility information. It's pretty standard stuff: your tax ID, phone number, street address. Indicate what you're applying in. Like I said, you can apply for more than one. Vascular interventional, you're going to start with that no matter what you're applying for. It's not going to break down all the procedure areas here, but it will break down the division. So you want to select vascular interventional to open that application. Once you do, you will get this tree, and this will be your guide through the whole application. If you have little yellow triangles, you know that you're not quite done yet. You might have to go back and fix something. The application is intuitive enough to not allow you to submit. So if it doesn't allow you to submit, go back, make sure all your steps are green and checked, and then you'll be ready to submit your questionnaire. And this is the questionnaire I was referring to earlier. When you're doing your facility assessment, just go through the questionnaire. If you don't have it, let your application sit idle for a little bit, go write your policy and come back to it. Talk a little bit about the site visit. The site visit is required. It's required for everything, the vein center and all the new divisions. We don't come out. It's not a surprise. We certainly don't want to catch you off guard, and we certainly don't want to make the trip and have you not be doing procedures that day. So you'll be notified by one of the IAC staff that it's time for your site visit. We will ask you to send a few dates and times that are good for you. We will be in contact with our site visit team, and we will select the most appropriate day. And you'll be given, ample notice as to, when the site visitor will be arriving for your visit. The site visitor will observe the patient procedures. This includes the sterile setup, the patient prep, the procedure, and the patient post-operative care. They will also look at medical records. They will look at your pre-procedure, procedure, and post-procedure notes. I reviewed all the requirements earlier, so you do want to go take a look at the standards and make sure that you do have everything that is required in that documentation. Be sure that your emergency supplies are inspected monthly, and they include a documentation of a list of all the supplies. You have to have a log that includes the medication, that includes the strength, quantity, lot number, and expiration date. You must, in the inspection log, it must include the staff member's name and the inspection date. So we mention this now because this is something the site visitor will look at. So we do want to make sure you are looking at those emergency medications, make sure everything's in there, they're not expired. So be sure to take a look at that before we come out for your visit. If you do autoclave on site, the site visitor is going to look at that as well. They're going to look at your autoclave log, make sure that it includes the results of biologic monitoring. This must be done at least weekly, and also includes sterilization records that comply with CDC standards. Once you're done with your site visit, you'll get your accreditation decision. You will either be granted for 3 years, or maybe, there's some things that we have to fix. Either way, it's all about bringing everyone up to speed and raising the standard of care. So don't be upset if you do get delayed. That's why we're here. People tend to get complacent in their day-to-days, and maybe, things fall through the cracks, and that's kind of what we're here for. So if you do get delayed, don't dismay. It just means that there's some issues or deficiencies that you must address and fix before we give you your grant. I will say, submit your delay materials as soon as possible. Don't wait, because your 3-year cycle starts when your application gets reviewed by the board. So if you hold on to those delay materials for a year, you're going to lose a year of your accreditation. Also, you only have a year to submit, so don't wait longer than a year for sure, or you will have to resubmit. But do it as soon as you can. If you have questions, give us a call. We'll try and walk you through it. We try to be pretty cut and dry with what's required. You will receive a letter that looks like this. This is if you're delayed. It'll say, hey, you've been delayed because this was missing. And then you'll see another bullet that says, hey, now this is how we fix it. In order to fix that, we want you to submit written documentation that, hey, from now on, our documentation will include this, that, or the other. So we're very prescriptive as to, what the problem is and how we need you to fix it. Once you have all that documentation together, in order to access, I'm sorry, let me rewind a little bit here. Access to your accreditation decision letter that I just showed you in the previous slide. This is all in your online portal. Now you don't have to sit here and check it. You will receive an email that says, hey, decision's been made on your accreditation, and it will give you instructions. It will lead you to the portal. You click on that little paper icon, and that's where you will access your accreditation decision letter. If by chance you are delayed, you would upload all those materials into the application in the same place as you would access your application letter, but you will use the tab there with the little open folder, and you can upload all of your delay materials in that folder. If you have any problems with that, please give us a call. We can reset it at any time. A little bit about things that do delay people that you might want to be aware of. Unfortunately, the most common deficiency we see is inconsistent infection control. We see contamination of the sterile field. We see improper sterile glove technique. Like I said, people just, go through the day-to-day and they become pretty complacent. So, if you're considering applying for any of these programs, I'd probably take a good hard look at that. Maybe start some type of quality assurance program just to be, maybe review all the staff members randomly once a month, whatever you want to do to make sure that everybody is maintaining that sterile field. Another thing we see are pharmacological or anesthetic agents that are drawn in advance are not identified. The room will get prepped and we'll have 5 syringes and 3 basins, and none of them have any idea what are in them. And maybe every day that the one on the right is on this and the one on the left is this, but it's a major safety concern. So when you draw those syringes or you put things in basins, make sure all of those things are labeled. Another thing, surprise, surprise, we'll come to the site visit and we'll meet Dr. Jones that we've never even heard of. So just make sure that all your medical staff, advanced practice providers, nurses, anyone that's providing patient care is included in your application. Super easy to add staff at any time. Another thing we see a lot of times are discordant findings. Like patient presents with ulcer, but they'll have a right SEEP score of 2 and a left SEEP score of 1. 9 times out of 10, or it's right-left disparities. We see that all the time. 9 times out of 10, it's an EMR issue. It's a, hey, I pulled the wrong drop-down menu, things like that. But these things really do matter. So you want to make sure that you go over all your documentation with a fine-tooth comb. We have many resources on our website. On the main website, under our program tab, there's the access to the standards for all the divisions. Any updates for reimbursement. If you want to see, who's around you that might be accredited, there's an accredited facility locator. The IAC staff directory is there if you need to get a hold of me or any of my colleagues. There's a sampling guidance document repository there, which is a golden ticket. If you're looking for any policies, chances are good we have them on our website. So if there's anything on the website that we have posted, feel free to use them, make them your own. That's what they're there for. We also offer on-demand webcasts and live webinars, like we are doing today. We also do special topics webinars that are super helpful. I think we just did one last week or the week before on deep venous evaluation and treatment, which was really good. That should be on demand soon, if not already. And then you can also go on there and try and find some CME courses if you're looking for CME. The guidance documents that I was referring to, they are located under that helpful resources tab. And the sample documents repository, you would kind of just do a little browse there. You would select the division, what category you're looking for, and then you can look at all the documents. I typically say, for the vascular interventional and the vein center, since they are fairly new, vascular interventional, I would just leave the search as vascular interventional and just kind of look at everything that we have. It's usually the easiest way to find things. The on-demand webcasts, they can also be found here online. Like I said earlier, if that deep venous one is not there yet, check back in a couple weeks. It's definitely worth the watch. We also have reaccreditation website webcasts on there for Vein Center, as well as this special topics for our new vascular interventional programs. And you can access information about any type of payment policies or CMS requirements. We also have some value-added services there. We use the QI tool. We do some MOC type of things in there if you need qualification for your MOC. A little bit about quality improvement. I talked a little bit about it earlier when I said quality assurance, because it's not, when I said check your sterile technique, that should just really be part of your everyday evaluations. But we do have a quality improvement section that is required, and it does have certain standards that you have to meet. The purpose of the quality improvement program is to evaluate your facility's current processes and implement a continuous improvement plan to maintain quality and safety for patient procedures. Your facility must have a written QI program to evaluate procedures on an ongoing basis. I do believe there is a cheat sheet online under the helpful resources. So I do encourage you to go and look for that. As part of the program, a minimum of 30 cases must be reviewed annually. You are required to have 2 QI meetings per year. So that would be 15 cases per meeting. Those cases must be evaluated for the following 5 metrics: their procedure appropriateness, technical performance of the procedure, patient safety, medical record completeness and timeliness, and procedure outcomes. For procedure appropriateness, we're looking at, is the procedure appropriate or usually appropriate, may not be appropriate, may be appropriate, or rarely appropriate, usually not appropriate. So you want to evaluate, and you want to be truthful. The whole point is to identify deficiencies. So, if we're not doing our quality improvement, if we're just going through the X's and saying yes, 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 it kind of defeats the purpose. I know everyone would love to believe their facility gets 100% score on everything, but chances are good there's probably something you can improve, even if it's the smallest thing. So make sure when you do your quality improvement, you do it accurately and truthfully. No IAC police are going to come out to your facility and come down out of helicopters because we have a maybe appropriate documentation here on one of your QI evaluations. So just really do it and make it worthwhile. You're going to evaluate your technical performance of the procedure. This includes completeness of the procedure, documentation of technical events, which would include equipment or device failure, the failure to perform the procedure, the quality of the pre-procedure diagnostic testing, that's very important, and adherence to facility protocols. Patient safety will be evaluated, and this will include the completeness of the procedure, Okay, looks like we have a little bit of a typo here. So for patient safety, we're going to look at complications. Please ignore this slide. We're going to look at complications. We're going to make sure everything was done safely. We're going to make sure everything was done using sterile technique. We want to make sure there's no, you know, loss of, equipment failure, or God forbid, loss of fiber broke off or things like that. So for patient safety, I do apologize. I didn't realize the slide was repeated here, but this is all in the standards. And if you have any questions, feel free to reach out to me. For quality improvement, for medical record completeness and timeliness, we talked about that a little bit ago, but I'm just going to expand on it. This is the time from completion of the procedure to the signature of the final report. This must be done within 2 business days. So all your final reports, your op reports, they must be signed off in 2 business days. Procedure outcomes, these are big buzzwords. The facility must have a written policy and process to track and document the outcomes of patients evaluated and treated. All outcomes in the medical record must be documented. All adverse effects within 30 days post-procedure must be documented in a central location. And each case requiring referral outside the Center for Treatment of Complications must be reviewed. And I'm going to go back to that central location. Why are we documenting our adverse reactions in the central location? Isn't it good enough to just put it in the patient medical record? Yes, it should be in the patient medical record, but in order to identify any type of trends, you want it in one location. You want one spreadsheet. You want one database that includes any type of adverse events that maybe you can link to something. Like I said, identify trends. Maybe there's some allergic reactions, or maybe there's some compression that shouldn't be used, or maybe there are devices that shouldn't be used. So that's why it's important to keep all that in a central location. Part of the QI, monthly emergency medication inspection log, I'm sorry, must be documented and reviewed. Can't stress this enough. I know we've already talked about it, but make sure that you do a routine inspection of this, and make sure it's included as part of your quality improvement. Make sure you talk about that at meetings. Make sure it's looked at. Your QI meeting minutes. So you have all that information. You've done the 5 metrics. You've looked at your emergency meds. You've done all that. So now what do you do with it? Well, talk about it. And not only do you need to talk about it, you need to document that you talked about it, because we are going to request a copy of your QI meeting minutes. Again, there are samples online. Please use and abuse them as much as possible. Each clinical staff must participate in at least 1 meeting per year. Your facility must have 2 meetings a year. We already talked about that. Has to include the case reviews with all those required metrics. They must also include a review of procedures resulting in an air karma of greater than 5 gray. Must include a review of monthly emergency medication inspection log. And after this webinar, if we forget that, we're in big trouble, because we have gone over that. We have drilled that into the ground. And then a verification of routine inspection of medical supplies and equipment must be documented. This is an example of your compliant meeting minutes. We're talking about all the measures here. And again, this is online. Download it, use it. If you have something that you would rather use, that's fine, totally fine. But it's got to hit all these measures. So that's why I encourage you to use this. If you use the meeting minutes, that we have an example of it, you are guaranteed to, most likely, shouldn't say guaranteed, to hit everything that you're supposed to with your QI. We don't have a lot of time to talk about our QI tool, but that is also something extremely valuable. That is in your, it's in your online portal. There's a QI tab there, and you can enter your cases in there, and you're just entering case information as far as like patient identifiers and procedure type, maybe provider dates, things like that. You're not uploading medical records. You're not doing all that. So it's not complicated. But what it does is, it will automatically generate questions about those cases for you to ensure that you are hitting all those metrics. So if you use our QI tool, you're guaranteed to have evaluated your cases proficiently. And at the end of that, you'll get a nice little report and say, hey, hopefully you didn't get 100. Well, maybe you got 100%, maybe you got 95%. But it'll give you a nice score and it'll tell you where your deficiencies are. Now, of course, it can't stop there. You still have to, we can't just have one person in the room down the hall doing this and doing nothing with it. You still have to talk about it in your meeting minutes. So you still do have to have this document. This is of the utmost importance. So again, we're here to help you. I understand there's a lot of standards. Some things might be a little bit confusing. The application, we strive to make it, as user-friendly as possible. But if you stumble along the way, always call us. We are here to help. You can contact me. You can contact Carrie. You can contact Heidi. If you want to see what we're all doing, you can follow us on Facebook, LinkedIn, YouTube. We also have some really nice broadcasts on YouTube about the value of accreditation. And you can follow me on Twitter or X or whatever we want to call it right now. It's really hard for me to call it X. But yes, absolutely. Stay connected. Find out what we're doing. Get your updates in real time so that you know what's going on at the IAC. That's it for Martha. You're welcome.
Thank you so much, Laura. So at this time, we will begin our Q&A session. And from IAC, I would like to introduce Heidi Bernard, our clinical specialist, and she is going to help with the Q&A session today. Heidi, did you want to start us off?
Yes, thank you, Michelle, and thank you, Laura, for that really excellent presentation. Lots of great information there. All right, Laura, so let's start off with a question about medical physicists. If your IR facility does not have a medical physicist or radiation safety officer, who would take that similar responsibility? I'm assuming they mean if they don't have one on staff.
Well, if they don't have one on staff, unfortunately, you don't have to have one on staff, but you have to have one. So I know that there are many, I'll think a lot of people contract that out. So you might want to research that. Yeah, you have to have one. Unfortunately, there's no way to get around it. They don't have to be a staff member, but you do have to have somebody appointed.
Okay. And then we had a couple of questions about site visits. Could you talk a little bit more about virtual versus in-person site visits? Somebody had noticed that for Vein Center, they're mostly virtual. When perhaps would you do an in-person? If you could just elaborate on that a little bit, please.
Thanks, Heidi. That's a great question. I'm glad that was brought up. For those of you who are familiar with the Vein Center, since 2020, we started virtual site visits because, of course, we had to. And I don't know that we expected to continue with virtual site visits, but they've turned out to be extremely, extremely valuable. So we have continued with that for Vein Center. Now, not all Vein Center site visits are virtual. First-time applicants definitely get an on-site visit, and then some of the reaccredits also get on-site visits. So it can kind of go either way. If you are a Vein Center and you are requested to have a virtual site visit and you'd rather us come out in person, we will certainly honor that if that's easier for you. Maybe not vice versa. If it's an in-person, it's an in-person. Now, with that being said, for the new procedure areas for deep venous, peripheral arterial, and hemodialysis, we're coming out. There are no virtual site visits for the new divisions at this time. They are all done in person.
Okay, great. And just to kind of follow up on that, someone asked about the cost of the site visit. Are they responsible for airfare, room and board, and that kind of thing?
Oh, these are wonderful questions. So everything's included in the application fee. There are there's no add-ons. I know I do believe there's some accrediting bodies, there are kind of add-ons and things like that. But no, for our purposes, your accreditation application fee covers everything. It covers a review of a delay. It covers your site visit, whether we come out in person or we do it virtual. There's no extra charge beyond your application decision or application fee.
Great. I know you touched on this, but if you could kind of go back over this again, please. Where can they find templates to use for, say, policies, protocols to use for their application process?
So we did have a slide on that. I don't think we can go back to that. It's in the online portal. And it's under helpful resources. Now I say online, yeah, let me take that back. It's not the online portal. When I refer to the online portal, I'm talking about your application portal. This is on the general website. So you want to go under intersocietal.org and you want to go under helpful resources. And that's where you will find the sample documents for all divisions. But there is a filter. Like I said, if you just switch it to vascular interventional or vein center, it will list all of the sample documents that are available for download.
Okay, great. Laura, when were the last updates made to, I believe they're talking about the standards for vascular interventional?
Well, the new procedure areas, they just came out. Right. So there really hasn't been any updates. I think there was one minor adjustment about it, but it was more of a clarification about FDA used devices. And that saying the new programs, I'm talking about deep venous for arterial and hemodialysis, which is another thing you just might say in your sleep tonight. For vein center, they were just updated, and they went into effect on November 1st. So there were some changes to the vein center standards on November 1st. So anybody applying after that time will be required to comply to those. I'm not going to get into the specifics of those because this is, a webinar that's geared towards the new divisions. But I will say, go on the website. All the changes are highlighted in yellow in the standard, so it's a no-brainer. You don't have to, compare apples and oranges. And also, I just had a webinar. Geez, it feels like that's all I've been doing lately. Within the past month, I think I've done a webinar, and that one should be available online, and that will cover all the new changes. And just as an added bonus, you can get CME credit for that. So if you missed it, listen to it, get all the updates, and grab your CME while you're at it.
Okay, great. Regarding the operative reports, can some of the required information be included in, say, like a procedure log or a technical log kept during the procedure? For example, your fluoro exposure and your estimated blood loss. Can that be put into a procedure log as opposed to the operative report, and they can upload that as well?
That is a wonderful question. And we are not the document police, okay? I don't care if it's listed under a document that has the title that says procedure note. As long as that stuff is documented prior to the procedure and it is included in the medical record, that's all that matters. So if if you have a nursing notes or things like that, and which a lot of people do, that absolutely is compliant. Just make sure you keep it and make sure you have it documented with the medical record. And more importantly, send it to us. If it's not in the procedure note, when we say send us the procedure note, and you know that it may not have all the required documentations, send those worksheets, send those tech notes, send those nursing documentation so that we don't, have to delay because, we're missing that documentation when, darn it, it was in your medical record the whole time.
Right. We'd rather have too much than not enough.
Right.
Okay. Let's see. With regards to, if applicable, do anesthesiologists need to be listed as staff in the application?
We do not have anesthesiologists listed as staff in the application. However, that may be changing. So I would be sure that you have documentation, you have all of their certifications, should the site visitor have to look at them, because it really is, when we come out for site visit, we really are at liberty to check everything. So make sure that you have all the documentation. But as far as volumes and things like that, we don't have specific standards for the anesthesiologist other than he or she just follows normal anesthesia, validated guidelines.
Okay, great. I have a question here about the QI metrics regarding medical record completeness and timeliness being completed and finalized within 2 business days. Is that applicable for both inpatients and outpatients?
Absolutely. Yep. We don't, the new applications, this is not just for hospital patients. This is for hospitals. This is for OBLs. And no, we do not have any different standards as to where it doesn't matter where the patient, well, it does matter where the patient's done, but it doesn't matter whether they're in an OBL or in the hospital setting. All those standards are applicable to either situation.
Okay, great. Another QI question here. Does the QI meeting interval have to be 6 months between meetings, or can it be sooner as long as there are at least 2 per calendar year?
That's an excellent question. So I believe the standards right. I believe the standards say that you have to have, does it say 2 meetings a year? Or does it say every 6 months?
I believe it's 2 per calendar year, because this is a grant, and I don't think it has to be exactly 6 months the way that they're written.
Thanks, Heidi. I had to really think about that one. So yeah, so it doesn't say that, but I mean, again, let's just go back to good practices. Let's go back to getting the most out of it. We're not in the accreditation business to just, we don't want this to be a checkbox application. We want you to do good work. We want you to evaluate things. So for you to do a QI evaluation in January and find deficiencies and then go back in March, I mean, it's just
right.
It's not good practice. So it's frowned upon. I will say maybe there isn't a standard, but it's probably not your best practice to really truly evaluate your facility.
Okay. Great. And then I think we have a little bit more time here. How long does it take to complete an application for accreditation? And then how long after submission will they get a decision?
It's a good question. So let me, in this last minute, so the interventional application is a little different than vein center. So with the vein center application, you submit your application, it goes to review, you get a 1-year grant, then you do the site visit. It's a lot more steps. For vascular interventional, you're submitting your application. I can't tell you how long it's going to take to complete your application. It really just depends on what policies you already have in place and what you have to write. I mean, if everything's in place, the application is fairly simple. Once it's submitted to us, it'll take about, I would say about a month or so, and we'll be in touch with you for a site visit. So there is no in between at that point. We're going to schedule that site visit. It's up to you to get back with us to dates for that. If you give us dates for 6 months out, well, it's going to be 6 months. If you give us dates for the next, 40 days, hey, it'll be quick. So it's kind of determined by you at that point. Once the site visit's done, the results go to our board of directors within the following month for evaluation. So kind of up to you. It can occur fairly quickly, or it can be drawn out.
Okay, great. Well, that's all the time we have for Q&A. So I'm going to hand this back to Michelle. Michelle?
All right. Thank you so much, Laura and Heidi. That was great. That was very interesting. And thank you so much, everyone, for attending. Please feel free to contact IAC with any questions that were not answered during the Q&A session.